When the patient is ready to receive their implant, we first have a CT scan taken and uploaded to our system. The CT scan is the start of the image to implant process, and here I'm going to show you how we take that CT scan and, using our proprietary software, design the patient-specific implants and instrumentation. Next, we move on to the femoral component. And we design the femoral component first because the rest of the components are going to be driven by this implant design. And then it places patient-specific J-curves on each of the 3 compartments. And these J-curves are going to restore the natural sagittal curvature of the bones, and the J-curves are going to define the outer surface of the implant. And it creates an implant that minimizes bone resection and maximizes coverage with no unnecessary overhang. Because our J-curves are patient-specific and independent of one another, they also drive patient-specific offsets in the distal and posterior region. So this offset that you can see here is patient-specific. The software places that cut and then defines a profile sketch. And this sketch is again going to maximize coverage with no unnecessary overhang, and it allows for 5 degrees of rotation in either direction. Looking at this coronal cross-section, you can see the curvature of the poly is designed to match that of the femoral component. That offset is matched by the poly as well, which is going to restore the patient's native joint line. While many companies have patient-specific instrumentation, our jigs are unique in that they facilitate the accurate placement of our patient-specific implants. After the jigs have been designed, they're compiled into our print frame, which is manufactured here in-house using 3D printers. And once the jigs have been printed, they're broken out of the print frame, cleaned, packaged, sterilized, and delivered for surgery. Here is our eye view, which is our surgical guide, and this will allow you to pre-navigate the surgery and know what to expect. And it will also show you if there are any notable conditions, such as hardware.
This is one of the many inspection steps that are performed during the manufacturing process where we ensure quality in every part that we make. All of the patient-specific features are confirmed and inspected against the original CAD design. This is another inspection step within our manufacturing process using an automated CMM machine, which is using highly precise ruby tip probes to confirm accuracy to the patient-specific design, measuring accuracies up to 3 to 5 microns, ensuring patient-specific performance.
I see a lot of younger patients with sports injuries, and those patients with degenerative knees and arthritis tend to be the younger patients, and that's a very difficult cohort of patients to treat with osteoarthritis. So the young patient with a severely arthritic knee, whose knee is too far gone for a biological reconstruction, but who's in so much pain they need a knee replacement at an age where normally one might be a little bit uncomfortable doing a standard knee. What Conformis has allowed is that it's given me a wider comfort zone, so I feel more comfortable doing artificial knees in younger patients. And what's terribly important to me with the Conformis knees is they allow the complete range of options. We can do a medial uni for just medial osteoarthritis, and what's really important is now for the first time we've got a really decent option for a lateral uni. And then if the patient's got medial and patellofemoral or lateral and patellofemoral, then we can do 2 compartments, and that's a very novel approach. And if the patient has 3 compartments, then we can do the full iTotal. So we've got the complete range, and what this allows us to do is to do the most conservative option for the patient depending on how bad their disease is. One of the deciding factors in choosing to move over to the Conformis knee was patient-reported outcomes. What I'm finding is the patients are much happier than they tend to be with a normal standard knee. The Conformis knee fits not just the size but also the shape and the contours of the patient's own knee, so it feels more like a normal knee. So we're seeing better patient outcomes in terms of satisfaction and function. The most obvious one is that patient-specific jigs fit perfectly. The jigs allow you to get the alignment right, the cuts perfect, the positioning perfect, and that's deeply reassuring. In terms of the bone that's resected, the bone cuts are very conservative. So you end up taking away just thin slivers of bone, compared to a normal knee replacement where you take away quite decent thick wedges of bone. And I think for me personally, the real stark contrast was going from an iTotal back to a traditional bog standard knee replacement, and only then did I appreciate how horrible it was doing the traditional knee replacement, which was much more archaic, medieval in its instrumentation, shocking in how much bone I took away. So it was only then that I really got a firm grasp for just how good the iTotal is and how good the iUni are. First of all, I explained that with a standard knee, they come in different sizes but all the same shape. So there's a size A, B, C, D, E, but the problem with knees is that the geometry of a knee is very complex. So each individual not only has a different size knee, but very different shapes, so different contours. So if you have a standard knee, then it's going to hopefully match closely, maybe not exactly, but closely the size of your own knee. It won't match the exact contours, therefore it's unlikely to feel exactly like your own knee. If you want a knee that matches the size, the shape, the contours of your knee, then you're going to have it patient-specific. It's going to be tailored to the exact size, shape and contours of your knee, and only the Conformis knee does that. So once I explain to people the differences between the Conformis knee and a bog standard knee, then most patients say straight away they want the best knee. They know this knee is hopefully going to be in there for 10, 20, 30 plus years. So they want the best knee for them, which is the sensible way forward. Conformis represents a massive leap forward. It's a sea change in the way that we approach knee replacements. It's a revolutionary improvement. It's leaps and bounds above any other knee replacement that's out there. And my patients, the patients that I see in my practice, they're very high demand and they expect the best. And the Conformis knee is the best. It is significantly better than any other prosthesis I've ever encountered. And so I have moved over to the Conformis knee as I want to provide the best possible care for my patients, and Conformis allows me to do that.
Let's start with F1. So from taking a little bit of the fat away in that suprapatellar region allows our jig to sit down here nicely. And you may see little gaps here because the jig's made on the cartilage surface estimate. Okay. We're going to start with a 0 cut. You can see it's set at the 0 position. 0, -2 or +2 for our distal femoral cut. And you can set that on this particular jig. We're going to start with the 0 though. So this is F2, 3. Get this into position. Okay, good. This particular jig allows you to place your recip saw if you have a reciprocal cut and you have an offset cut. This happens to be a flat distal cut, so we don't need the recip saw. Probably the most important thing with this distal femur cut is that you take your time and let the saw do the work. Okay. So what we did was pre-mark our pin sites so that we can see them after we make our distal femoral cut. We're going to take our pin out and we'll see how flat our cut is. See if we like it, make sure we don't have any of those. There you go. We've got a nice flush cut. Both sides really look super. What you'll see is if it's a little high in the middle, this jig will rock back and forth. But right now I've got a nice flush cut. So on the bottom of the tibial guide, we put some pen marking so that when we put this down in its position, it will release a mark on any leftover cartilage. It's really important to look at your eye view ahead of time to see what it looks like as far as the window, where that's going to be in relationship to the tibial spine. Looks like it's really right on the medial side. That looks good. So we're going to shave off a little bit of the remaining cartilage. All right, we'll take the jig. This is a patient-specific jig. His native slope was 13, and this is maxed out at a patient-specific 10. So you're going to use all of your guides here. So you're going to be viewing it from the side. You're going to be viewing it from the anterior view. You're going to be looking at your window up here to make sure you're in the right position. You're going to be looking at the foot pads to make sure they're down properly. Because he has a high LL number, we're going to use a -2 cutting block so we preserve a little more bone. This is a captured -2 block. You can either use it for -2 or +2. Okay. Bobby? Give me the T3. So we use this jig in flexion. I'd say that's a pretty good fit. If we have a real deficient, it should be a little sloppier on that medial side because we're pretty deficient on cartilage. The lateral side isn't, and it fits really nicely. I like the way that is fitting in there. That looks good. Now let's make sure we're good in extension. I'm going to take T2. And then we can test. Yep, and he opens up just a millimeter that way and just a millimeter or so that way. So valgus and varus is pretty close here. So I think our flexion extension is nicely balanced, and I would move on and finish up the femur now. Let's go ahead and take that femoral pin out to proceed forward on our femur. So back to the femoral side. So this allows you up to 5 additional degrees of rotation. But I found that this actually is most of the time at 0. And you want to have your assistants make sure that both sides are flush. Go ahead and pin this. One more pin. And then this pin comes out because you have to cut your chamfer cut. I just leave the other one in place. All right. There's an anterior referencing L guide. We'll take that. This is an additional check anteriorly. So just like an angel wing, make sure that this is flush, that you're not going to notch. Okay, we're going to take the saw first. And so if you can just bring your finger in there. No, you don't need anything there. Just bring your finger in and keep that perfect. That's it. And I like to notch this whole cut right here, the whole way across, so it's nice and smooth. And I always complete the medial side first. And this anterior cut is very, very reliable. And your anterior chamfer cut. Again, I like to just score the entire cut first and then let my saw blade run through. Good. Pin, drill. Pin puller. Okay. This is 5/6, a dual chamfer block. Make sure the alignment's good. You can see what kind of nice fit we have here from the side. Okay, so those are your last two chamfer cuts. Very, very small. All right, so we're going to take our femoral trial. It's going to go in and we're going to see how this fits in relationship to the native anatomy. From this angle, it really fits nicely. You can see the internal piece, how nicely it fits. So you can really see how nicely that contours to the native femur. You can see inside, let me see it freer, how this implant fits the native anatomy here really nicely. Can you see that? Well, same thing on this side, and same thing on the medial border. So very important to take away those osteophytes as they change our balance. I'll take the A6. Okay, so flexion's quite nice. We like that. So I really like the extension. It just slides right down. I have just a millimeter of opening here and a millimeter or so there. Mid flexion, nothing. Good. Now, what I like to do too is if you take the eye view, so this view right here, if you see the center part of the tibial tray and its relationship to the tibial tubercle. So you want to look at this. The center of this is going to come out just to the medial edge. My little arrow is going to line up just at the medial edge. This little arrow here is going to line up the medial edge of the tibial tubercle. That's how I know that I'm in proper rotation. So if I want to check my alignment here, I can get a view this way. Okay, I'm really well aligned. I like the way that looks. And I can see it from this angle as well. Okay, let's see the tibia. So we can come back to that basic mark that we made. We know we've got a little fight right here we're going to take off. And so I'll again align it roughly with my mark and also the anatomy. And I'll just fine tune it. It gives you about a 5-degree arc of adjustment here. Okay, and then I'll take first pin. Good. Yep, always put the lateral one in first. Medial one. This is also a spot right now where you can use your alignment arm if you wanted to, but this one goes back, gives you a little better purchase back here. You can see what osteophyte I still have remaining. I'll take the collet. I think you can probably see from over here how our centerpiece is lined just on the medial edge of the tibial tubercle, just like our eye view points to. So I'm pressurizing the cement into the cancellous bone. Okay. important to start front, slide this in, and then I like it to do it by hand. You feel the snap. Again, slide it in, done. And then you use your PCL retractor and a little assistance to lift it up like that, and it'll slide right in. And now we're right in alignment. So I like to have about 2 to 3 millimeters of cement penetration. This implant is going to go in, it's going to hug the contours. We've got our 2 holes, peg holes. So I get it in just finger pressure tight, hand pressure, and then we'll impact, bring this back a little bit right to here. If you can bring this down a little bit or back, maybe you can see that better from that angle. I think you can make out pretty nicely from the side here what a perfect anatomic fit that is. Really fits like a glove. And we'll take a look at how this final seating looks. And that's right down the pike. That looks great. So easily, and patella seats nicely in its groove. A very sort of complicated case with a lot of factors. Look at that, nice and solid there. Just should open up a millimeter or 2 there on the lateral side. Balance right through mid-flexion, full flexion, full extension restored, and it feels nice and smooth. So that's a wrap.